good on here. All right, you guys ready?
Yep.
Welcome to the EMT Pro podcast, where we deliver relevant content from the field and the classroom each month. Episodes of this podcast can get you 1 full hour of CE through our partner, emt-ce.com. So head over there for more information. I'm your host, Steve Williams, and with me today is Dan and Holly. Guys, welcome. Say hello.
Hi,
Good
Steve.
to have you.
Hello. It's good to be back.
We're back. We're shooting for an episode a month this year. That's the hope.
Yeah.
We're going to do it.
It's been tough.
It has.
And here we are.
COVID was tough.
January
Jobs
6th.
are tough. Yeah.
Do you think like coming back from COVID was tough? Because it was like we didn't do anything and then suddenly we started doing all the things again.
Yeah.
It's been a tough
people
transition.
And like companies and people weren't ready for that like quick rebound.
No.
You know?
Or
So-
parents.
Or parents. Yeah, no kidding. Oh my gosh. All the sporting events and
Oh,
kids' activities.
all the people.
Yeah. Yeah. Well, we got a fun episode today. We're
I
gonna be
think so. I
talking-
think it'll be good.
About basically the multitude of ways. We're going to hit on a few of them, not all of them, but some really good ways to set yourself up for success. And we've got some examples of why these lessons should be learned. And hopefully you guys can learn from our mistakes and our some people who've shared their stories with us, mistakes that I'm going to go over today. And I'm also excited to hear about a couple of these, primarily this one checklist that you guys have that you want to go over, that you guys helped develop.
Yeah.
For your previous agency.
Previous.
Awesome. All right, here we go. So, I want to talk about cardiac arrest because back on, oh boy,
It's
how
been
long
a
ago was
while.
our chat with Joe Powell from
Probably
Rialto Fire?
a year and a half ago, maybe.
I would say that.
So
a
he's
good long
now
time.
retired, and he actually told us after our episode with him that he was soon to be retiring. And let's see, that was September 8th of 2020. Yeah. That was
2020?
That was when the episode launched.
Wow.
That was a long time ago.
Yeah,
My life is
Okay.
just slipping away.
yeah. We're here though.
Barely.
So that podcast with him really motivated me to get some stuff in gear in our department. And so I took a bunch of his data and
And just reminding people again that he
Yeah.
does the heads up CPR.
yeah, so the Rialto Fire model is something that I believe is constantly being tweaked. So it's, it's always under revision because they're trying to find, if I could summarize it, the best combination
Yeah.
of new treatments and, treatment modalities to get the best, neurologically intact survival
Mhm.
rate, or the Utstein criteria, or Utstein, I don't know how you pronounce it, but actually while we're on the podcast, I'm going to see if I can Google any
Utstein?
changes. No,
Oh.
any changes that
I'm all
Rialto Fire
The
It's
old
kind of fun to
Utstein.
say.
has
Sounds like a
done.
beer.
Where we're working, where Holly and I are working, we're moving to the heads up here pretty soon.
Mm-hmm.
With some variations, obviously, but
Yeah.
that's where the movement's going.
Mm-hmm. Yeah, so to kind of back up a little bit, after that interview with him, I had already been looking at a lot of the Rialto Fire stuff because I was tasked with putting a bunch of changes to the way we do cardiac arrest. We were kind of stuck in the pit crew CPR model, which is great. I mean, you
Right.
still got to have that,
Right.
Because you have to have, known roles and responsibilities,
Mhm.
Yep.
and those have to be clear, right? And you only get there by having a plan in place and by training on that and everything else. But the way we were approaching cardiac arrest wasn't changing much more than, ACLS with a pit crew CPR a component attached to it. And so, it's hard not to pay attention to a department that is throwing out numbers like 71%,
Yeah.
Yeah.
cardiac survivability rate.
It's amazing.
When looking at the Utstein criteria with their with the way that they approach it. So I went to our department managers and said, hey, this is what I'd love to lead the charge on and see if we can get some things put in place. And there was some hesitation for sure, but I got the right people convinced, I would say. And then from there, it was a slow process of getting it pieced together and kind of building a team to help train our department and get some things set up. But one of the things I remembered most was, when I first started in like 2006 timeframe with EMS, I remember watching certain paramedics run a cardiac arrest call and see they were following ACLS, but some, we had a couple that were like right near retirement, and they would revert back to the ACLS they learned, 10, 15 years
long
prior.
Shock,
right?
shock.
Yeah.
Everybody shock.
Yeah. Hanging mannitol. It's like, dude, we
Right.
don't carry that drug anymore. It's like, oh, yeah, shoot. And so I just remember thinking, shoot, shouldn't this be a little more organized, And I'm a very, anal retentive type person. I like bullet points. I like checklists.
I didn't know that about you, Steve.
Yeah. Yeah. I don't like disorganization and, not having a plan. That gives me anxiety. So I got, I'm not telling you guys anything you don't know. But I got this buy-in, and we created these steps kind of thing that was based off of the Rialto fire model at our local fire department. And so I'm going to pull that up real quick. But we start, so first off, one of the things that, and this is not we are not sponsored by Zoll in any way, shape, or form, but hey, Zoll Medical, if you guys want to throw us some cash, we would absolutely take it and sell your products more. But one of the things we did was we went to an all Zoll system. So Zoll ventilators, the auto pulse devices, the X series monitors. And so that kind of, whether it's Zoll or Physio or whatever, system you're with, I think it's important that it just seems like things work better when you stay in one ecosystem.
Absolutely.
Mhm.
It's a great idea.
It's like you don't see a lot of people mixing and matching Mac and PC,
Right,
kind of stuff.
right.
But so we created these steps, and I'm going to go over them here in a second. But I was curious what you guys, what do you remember? What you're with the new agency you're with? Tell me what they're doing with cardiac arrest response.
Well, we're definitely not on any type of cardiac checklist yet.
Mm-hmm.
Nothing like that. I mean, some of the places up here aren't even at the pit crew approach
Yeah,
step yet.
yeah, I've seen that too.
Which is, I mean, it's like when I started back in the day where you just kind of all stand around saying, what do you want to do?
Mm-hmm.
And we are going to the heads up variation. There'll be some different things than Rialto did, but it's coming.
Mm-hmm.
They're seeing the benefits of it.
Mm-hmm.
Do not have a checklist yet, but really anxious to see yours to see if we can move it
Yeah, I
forward.
might just send you mine.
Yeah.
See what
Yeah,
you
that'd
can
be
build
awesome.
off of that. So we start, currently we have an 8-step model. It took us switching physician advisors and
to do that.
and EMS chiefs to get to the 10-step model. So the 10-step model is in the works. It's already been created, but as far as it, adopting it and putting it in play, that's kind of where we're at currently. So with that, we start with step 1, manual CPR. We show up on a scene.
Mm-hmm.
We start pumping on someone's chest. Obviously, no different there. High quality compressions, 100, 120 minute. Move on to placing the stat pads. And the interesting thing about Zoll is their packaging for adults recommends anterior posterior placement. However, they say it'll still work, top right shoulder, bottom left on the side. But for whatever reason, they recommend anterior posterior with their pads, which I don't think the other ones that I've seen, at least I never paid attention to it if they did, but I don't remember ever seeing that.
We, for pad placement, we do double sequential where we work. So we have 2 different monitors. So the first crew will come put just below the xiphoid process, and then the left scapula, and then the next crew that comes in after the third shock will put them whatever this is, and no one can see me pointing to where I am right here.
Yeah. Top right.
Yes, top
chest
right.
and
Yes.
lower
Just
left.
Like the
Tradi-
typical anterior
traditional.
placement. Yeah.
Right.
Yeah. So you guys are involved in a study then. That's not,
That's done.
you guys are
Now it's just
you
a
adopted
protocol.
right on. Very cool. So yeah, we place stat pads. Obviously, the whole goal with each of these steps is the absolute bare minimum interruption in compressions, because that's
super important.
Yeah. I remember Joe saying, "Nothing trumps compressions. Nothing."
When you have that on, is there a pause button to analyze or to shock or anything like that, or is it just continuous?
Nope, it's just continuous. It has a you basically have your compressor stop briefly, and when he's off the chest for just a second, you put that CPR feedback puck down, and then you continue your compressions. And so it's really like an interruption of maybe a second or two at max.
Or are you talking
I'm sorry.
about
I was talking about the auto pulse. Is that what it's called?
Yeah.
Oh, no, these are just the pads. We haven't gotten to the
we haven't gotten
auto
there yet.
pulse.
Okay.
Gotcha.
Yeah. So step 3 is BLS Airway, so obviously delivering BVM ventilations. But if we go to, what we'll go to essentially here pretty quick is apneic oxygenation, where you throw a nasal cannula at 25 liters in their nose, and then you have that roughly, I think it's 10 to 12, I could be getting this wrong, 10 to 12 millimeters of mercury vacuum that's created by the auto pulse device that actually draws that air into their lungs just enough to, it works great.
So can I ask you a
Oxygenate.
question on that?
Yeah.
Because that's all kind of new to me. So is that in lieu of the BVM?
No, it's, you're doing what you can get to, right? And so if you have a BVM in front of you and you don't have a nasal cannula, then you're moving to, whichever one you have.
Where does, and I hate to even say this, but where does the iGel even?
iGel is coming. Yeah, a couple steps.
Oh, okay.
Yeah.
Continue on,
So-
sir. I apologize.
No, you're good. You're good. So next is placing the auto pulse. So we only place that device when the patient is considered viable. So if we have someone unknown downtime, found an asystole, and we're kind of going through the motions, we're not going to put an auto pulse on.
Right.
It's also got a limitation, roughly 26 to 56 inch chest widths. So we kind of say roughly the little grandma is kind of the minimum, and the 300-pound lineman at the college is about as big as it gets.
Yeah.
And then once that's on, things are great. That device is so amazing.
Just go get a coffee.
Yeah, you have so much time. We move into ALS or BLS airway placement, depending on who the crew is. And obviously, if you're an ALS provider, you're going to be looking for a tube. And some prefer to just go straight to an iGel, but we really emphasize, especially with video laryngoscopes, getting an ET tube.
Can I interject here?
Yeah.
I mean, I'm 100% with you because, you look on my sleeve, I'm a paramedic, right? I am a paramedic. I'm not a 5-star paramedic.
You're wearing a sweatshirt today, but yeah. Yeah, I get you.
What's best for the patient? I mean, if I'm going to do an airway on a cardiac arrest, I want to do the tube because I went to school and I'm bored at these abdominal pain calls. I want to do an intubation, right?
Okay.
And so I don't know how many times that I've just let the person just sit there while I'm getting all my stuff prepared, even though I got 10 people standing around me, and they're not being ventilated, but I get the tube, right? Why not just anytime we're going to put an OPA in, we put an iGel in. We get all our stuff prepared, and then when the intubator is all set to do it, pulls the iGel.
I mean, I don't think that's a bad plan. However, I think you are leading us into a great segue into airway checklist, which we're going to get into at the conclusion of this checklist.
I think that as long as the patient's being ventilated, it's fine. Like if you're doing, like in your old protocols, you would stay on scene for 20 minutes. That's plenty of time to intubate somebody.
Right.
As long as they're being ventilated in the meantime.
Right.
Yeah.
If you feel like they're viable and you're going to transport and you can do a tube without sacrificing SATs or time or chest compressions, then why not? But I do think it's risky to put some airway in, remove it to put another airway in, because a lot of times vomit will follow, or maybe you're just not going to be as successful the second time around. But anytime I've ever seen anyone get extubated or swapping out an airway,
It just doesn't work.
not that it doesn't work, but there's a lot of times there's vomit. Like
Yeah.
there's stomach
Yeah, yeah.
contents that come back out.
Oh, totally.
Yeah.
But then again, maybe most places these days just go straight to iGel. They don't even consider an intubation. So I think it's appropriate for either.
Yeah. And I think it comes down to, I mean, shoot, if we're being really honest, our staff is so young and they are less and less experienced.
Yep.
And so if they can move to an iGel and keep going, I'd
And
much
not
rather have
sacrifice
them do
compressions.
that and not sacrifice compressions. Throw an iGel in, forget about the tube for now.
Yeah.
You can do that when you have a more experienced provider on scene
Yeah.
and move on.
Yeah. you got time. You've already put an
Yeah.
NG, OG in.
Mm-hmm.
Yeah. So I think the cool thing about our checklist is it does allow for some
Okay. Flexibility.
there.
All right.
Does your medical director have a preference?
I don't know.
I mean,
haven't asked him.
ventilation's the goal, right?
Right.
And iGels are safe.
Yeah.
I think it's a great.
I know
First
he's a
step.
big, I mean, as I would assume most physicians are, he's evidence-based practices.
Right.
Yeah.
He's key on. So he wants to see the data behind each
Mhm.
thing we're trying to change.
Which is good. And
Yeah.
if you take someone in the ER doing compressions with the iGel, they're not going to immediately switch it out.
No.
Right.
Unless it's not working.
Very true. So the next step, and we kind of move into the ALS steps here with cardiac arrest response. OG tube placement. You measure and place the OG tube. Air is removed until stomach contents are seen. And, I would say when people don't have this checklist out and they're running a code, this is the step they always skip.
Yep.
Always.
Exactly.
This isn't quite in the paramedic
Um,
checklist
Right.
in their brain.
Right. And it's really important.
It's
Like
It
there's
is.
super
data
important.
behind why we should be
Yeah.
removing the extra air we're shoving into their stomach.
And a lot of the private ambulances around here where we work don't carry NG, OG.
Really?
Yeah.
Oh, that's a bummer. They're so cheap.
I
Who cares? It's a quick thing. Anyways, after that, we move on to our IV or IO placement and medication administration. And so, and then the last step is transport. But the cool thing that I really like about this whole process is, if you look at ACLS, you want to give your first medication in that 3 to 5 minute window of, the second round of CPR, right?
Mm-hmm.
And so this, when you have a team of, 2, 3, 4, 5 people, and we actually practice with groups of 2, groups of 3, groups of 4, groups of 5, so that we know how it changes with each of those response models. When you're on your game, you can get to this step, have an IV in right around the time you should be pushing your first drug. And the teams that were doing the best with it when we started timing them and videoing them, they were ready to transport, had the patient on a gurney in the back of an ambulance from our training facility EMS room in just over 5 minutes. And
That's
so
awesome.
they're smoking it. And when you practice it, obviously practice makes perfect. It's very doable.
Yeah.
And
so
practice
really,
does make perfect. And the good thing about having your checklist is that maybe you've practiced a bunch, but maybe some of the other people you're with have not practiced.
Right.
And so it puts everybody on that same level of
Yep.
step by step.
And
This
it's
is what
right
we're
there in
doing.
front of you.
Mhm.
yeah. And so checklists are awesome. And I think one of the things that we would emphasize on this podcast, if you're listening and kind of wondering how you can affect some change at your department, go do some research and come up with your own checklist that incorporates your current protocols and just organizes them in a fashion that can be easily replicated by the various providers at your agency.
And you can make a checklist for anything. We have one for stroke, we have one for RSI, cardiac. And I used to work with, remember Mark Hostat?
Mhm.
Yeah, Mark Hostat was a Vietnam era helicopter pilot. Thousands and thousands of hours in a helicopter, under combat, under fire, all that kind of stuff. And then on life flight, we'd get in the rig, he'd start up, he'd have a checklist out. He's done this thousands of times, but he still has that checklist out to make sure he does all the steps.
Yeah. And I think there's a, misconception that if I use a checklist, I'm a weak paramedic.
Yeah.
And I'm not as smart as I should be.
Right. Should be
And
memorized.
I shouldn't have to rely on this, and I don't know a paramedic who treats a pediatric patient without a protocol out,
Absolutely.
because you do it far fewer times in your career. And you also have that as kind of your, I know what I'm doing here. This is the right drug.
Yeah.
This is what the Broslow tape says blah, 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 blah. And
There's
we don't hem and haw in some areas, and then we hem and haw
Yeah.
for
Yeah.
a different patient. It's like,
Yeah.
come on, we're better than that.
I did not grow up ever using a checklist.
Nope.
It was memorize your protocols, know the doses, which is good, and you should. But at the same time, that's a very single person approach. We're all kind of type A.
Yeah.
And so I'm in charge.
Right.
Which means I'm going to do this. But we really need to step back and bring the whole team in, and that's what a checklist does. It takes it from like a single person approach, like the PIC approach, to a group approach, which is how it should be.
Yeah.
That way everyone's involved. We can all bounce things off each other.
In the ER, right?
There's a checklist for the sterile procedures. There's a checklist for sepsis. There's a checklist for everything.
And that's in a controlled environment. We get on, on the back of someone's ambulance or on a hill somewhere. We, it's not controlled. We need something to kind of ground us a little bit.
Yeah.
Yeah. And it really does bring everybody into like center focus.
Right.
Instead of you're over there doing something and I'm over here doing something and we're just hoping we're all doing something.
Center focus. I haven't heard that before.
I just made it up.
Jeez.
Nice.
Surrounded by smart people.
So that's a good reason why, why we use a cardiac arrest checklist. We have these cards with those steps printed out, and they're everywhere. So
I think it's awesome. I've never done that before.
Yeah.
But I would like to see us do it more. And you just talked about all the stuff they're doing in an ER with various checklists, and we need to be doing the same thing because, I would say our most often, one of the things we go to the most is we're in the back of the ambulance, we're treating a patient on some protocol, and then we look to our other fellow providers and go, is there anything else we should do? And that's a great question to ask to get other people's, thoughts and, comments and concerns or whatever. But
if they know what you've already done.
Right.
Or what you're thinking.
Yeah. But the problem with that is it kind of alludes to the fact that we're not going off of a checklist that we should be. And I want to emphasize that this is for the patient that you've determined this is what it is. It's not
right.
It's not I need to go down this checklist because I think this is what's going on. It's like, we're doing this because this is what we've chosen to do, and we want to make sure we hit all these steps in sequential order.
Yep.
But I want to talk about your guys' Airway checklist because I want to try and get that pushed through to our department.
Well, if you look at the evidence, if you look up any study, which you can Google millions of studies, no matter what checklist you're using, they all have positive outcomes. Whether it's first pass success rate, whether it's like better like peri-intubation phase, no hypoxia, no hypotension, it's always better to have a checklist. The outcomes are always better, which is why the FAA uses it, why hospitals use it, because it is evidence-based.
Yeah.
But it's a culture change for us to do it in the field because it was never really pushed by anybody else.
Right.
But we
and
did.
Our pride gets in the way.
Our pride gets in the way, yeah.
Absolutely.
It's like putting the IKEA desk together without the instructions, right?
Oh, this is a new one. Let's go with this one. What are we doing? Tell me about the IKEA desk.
Well,
Sounds like a personal experience.
I bought my wife a desk, and I don't need those instructions, right? And then this drawer does not fit in the hole.
Yeah.
So I had to go rework the whole thing and follow the instructions.
Yeah.
I bought my daughter an IKEA desk as well, and I used the instructions. And I still put it together backwards.
Nice.
If I had someone there to bounce the checklist off, maybe everything would have gone fine. But anyway, to this day, it's still put together wrong.
Wow.
She has no idea.
Oh my goodness.
I told her it's because she's a lefty. That's why everything doesn't quite line up.
Blame her. Blame her for that.
Anyway, back to the Airway checklist.
Yeah.
So we work like in our past lives, we worked in the arena of air medical. And so usually you're coming into a situation where you're always working with another agency that you've probably never worked with before. You don't know what their protocols are. You don't know what their capabilities are. So when you go into a scene and you're going to need to intubate, there's a lot of like organizing what we're all doing because the two of you, you and your partner, can't always do it alone, right? And once we started teaching this to all of our new hires, it was like we were just kind of drilling it into their heads about all the steps we have to do. I remember being on scene once, and I get in the back of the ambulance, I'm going to intubate, and it's a complete. Was I with you?
No.
Oh, I probably told you about it.
It was my department, though.
Oh, no. This is a different story.
Okay.
We'll tell that one later. But I get in, it's this rural agency, and I jump in, and they have everything ready. They're ready to intubate. And I was like, well, I'm not ready because I still got to get some stuff ready, and we have to pre-oxygenate. The suction wasn't plugged in. The oxygen wasn't hooked up. The monitor was behind somebody facing the wall.
Yep.
And I almost got sucked into it.
Yeah.
And like, okay, I'm ready.
Yeah, let's do it.
Let's push the drugs.
Yeah, people are pushing you from the outside, and once you get that done.
Yeah, but after teaching so many cadaver labs and doing it step by step, it made me stop and realize, like, okay, do we have suction? Do we have, Yeah. And that could have gone wrong pretty quick.
Yeah.
Because nobody was watching anything. If I had needed suction, it wasn't plugged in. Then you're fumbling around for it. The bougie had fallen on the floor. So the checklist is really important just to refocus everybody and walk through it.
One of the things I've seen, I would say the most common quote-unquote checklist people do, you can't even call it a checklist, it's just the one thing they may do before they actually start the intubation process. Is my backup ready?
Yeah.
And then once someone says, yeah, I got a backup here, they're like, okay, game on, and on with the intubation. And we are creating a bit of a false sense of competency with video laryngoscopes, in my opinion, because some of the brand new guys, that's all they've ever known. And so if they ever had to, what if that screen goes blank? What if the battery dies? Obviously you have a intermediate airway you could throw in, but if you're going to intubate, and we got to be able to do both skills because, we could do a whole thing on
we could, yeah.
DL, VL, but.
And what that checklist does is it takes over the ego, right? So this person has 2 tries, and if your stats get down to this number, you have to pull out. It's not like this is my interpretation versus your interpretation. It's right here in writing. So
yeah, I did not believe in checklists really until I went on a call with your agency, and the checklist I don't think was used appropriately.
Nope.
However, we had some discussion afterwards because you don't want to go through the checklist at the detriment of just leaving your patient there to languish. You have to still be doing stuff. Sometimes, right?
Yeah.
While you're going through the checklist, instead of like everyone stopping what they're doing and reading the checklist together
from top to bottom.
Right. Like from the top, meaning is there an indication for intubation?
Right.
Like, okay, let's move along here. The blood pressure is dry. So certainly when you have your checklist, there's certain things on the checklist that you want to have, like positioning. Who
Crucial.
forgets to position their patient?
All the time.
The majority of us.
Me too. I
Right.
mean, and we teach this stuff, right? Because I was never taught that. Oh, I don't have to intubate under the semi-truck.
Right.
I could move them to a better
Yeah.
location.
No.
Yeah.
Right. Or in the bathroom. Like
Yep.
try to make your first attempt your best attempt. So positioning is really important.
Positioning. Pre-oxygenation. That just buys you some time. Gives you
Yeah.
some safe apnea time.
It seems like that's a pretty well adopted thing lately is the pre-oxygenation.
It is if it's in writing, but then
It's
you
in
get
writing.
you get on scene and people kind of throw some of the stuff out the door because they get the stress gets involved.
Right.
Stress takes over.
Yeah. So positioning ear to sternal notch, as Dan says, ear hole
Ear
to
hole to neck hole.
to neck hole.
That's a Dan thing that I have in the back of my brain.
And if they're a trauma patient, you can lift the gurney up.
Yeah.
And they want 45 degrees. That's really high. That's almost sitting straight up.
Yeah.
But any kind of elevation of the head is going to help you get a good view.
Take that C-collar off.
Take the C-collar off. We talked about pre-oxygenation. So what does that mean to you?
I'm going to denitrogenate them, which means I'm going to fill their body full of oxygen, get rid of all the nitrogen, and it gives us, depending on the health of the patient, gives us a lot of time.
So nasal cannula as high as it can go? Or,
Yep. Niscan highs go non-rebreather for at least 3 minutes or 8 vital capacity breaths of the BBM.
Yep.
Which I
which
never
is
really
awesome.
knew what a
So-
vital capacity breath was. But I guess it's
full breath.
3 big ones or 8 big ones.
I'll
Right.
put a link to a pretty cool video we made a while back that defines in a picture what each of the airway definitions are and lung
Cool.
definitions are. It's
Awesome.
pretty slick. That's one of them.
Awesome. Yeah, and while you're pre-oxygenating, that's like built-in time to go through your checklist right now
Right.
because you're going to pre-oxygenate. Even if you're on the side of the road or it's raining out or whatever, RSI is not rapid.
Mm-hmm.
It
Right.
takes time. If you want to do it right and
If
if
you
you
want-
want your patient to have a good outcome.
Right. Because you may end up having a successful intubation, first pass success, the whole thing, but you've done things out of order or not in line.
Or their SATs have been
SATs are
80%. Maybe they got hypotensive for a brief
Hypotensive.
period of time.
Right. So this gives you the time to take care of, or at least try to take care of that stuff.
Yeah. So you're pre-oxygenating. At this point, make sure you have your suction. Make sure you have a monitor person.
And by that, this is where I've had issues. You get, 10 people in the back of that ambulance. You have your monitor sitting there, and just like you said, it's facing the other way or something. Everybody wants to look at that video scope.
Yeah.
What do you see in there? It's like, we're watching a movie, and no one's watching the SATs drop. The
Right.
monitor tech is responsible for letting you know when you get to that pre-designated number. Okay, I'm pulling out at 94. You tell me when it gets to 94, heart rate gets less than 60. So that's their whole job, is watching that monitor.
Yep.
And letting me know what's happening.
I think, most people do all these things, but having a checklist really does. You can have someone calling it out to you. So we did position, pre-oxygenate. One thing during that time is like we're getting our equipment ready. Not just say, is my backup ready, but what is your backup plan?
Yep.
My backup plan right now is going to go back to BVM because it's working.
Yeah.
My backup plan is a iGel. My backup plan is going to be a crike.
Right.
Whatever that is, make sure everybody knows what your backup plan is. So when the intubation fails, everyone's not just scrambling
Right.
to do
Everyone knows what's going to happen.
something.
Yep.
Right.
Right. And I've given myself permission to do that crack if I need to.
And Dan, one of the things you told me that you were getting in the habit of towards the end of your career was putting a Sharpie mark on where you're going to make the cut for
everybody
your crack.
sees it. Everyone knows where I'm going to do it. I've got a general idea where it is.
Yeah.
And it's not a big surprise.
Yeah.
I mean, I've done some cracks where people were surprised when the blood starts squirting out all over the back of the rig. Like, what are you doing, dude? Because I didn't tell them.
Yeah.
Right? It's like, mad scramble.
Yeah. The other thing that I think a lot of people don't remember to do is to resuscitate their patient.
So important.
So if you have a patient that you're going to RSI and you're going to give paralytics to, paralytics are going to paralyze everything, right? Muscle tone.
Yep.
Maybe your body is in shock already, or maybe like the first stages of shock, and the muscles are all contracting to shunt that blood up to the core of your body. If you relax everything,
Where's that blood go?
where's that blood go, right? And any instance of hypotension in a trauma patient increases their mortality.
Yep.
Even just for
Yep.
a minute. So you really want to be sure and resuscitate your patient before you give paralytics.
Right.
And that could mean some fluids. That could mean blood. That can mean push dose epi. And those things, if you want to have like a map around 65, maybe 70, depending on if it's a head injury. And you want to try to keep it there before you push a paralytic.
Yes.
I know that's not always possible because nothing's perfect in the
Right.
field.
Right.
But you want to be thinking, if you do not resuscitate that patient, you give them sucks, they're
Things.
probably going to code,
Right.
right? They're going to lose their blood pressure, lose their SATs, get hypoxic now. And so you're just creating all of these bad outcomes. Maybe your intubation's going to be successful, but if you had hypotension or hypoxia during your intubation, that is not a successful
Right.
intubation.
And don't just say I will do that. Get your push dose ready.
Right.
And even if it's on the border, give a little bump.
Right.
A little bump. And the same thing, get your compressors ready as well. Get your drip all set up. That stuff's cheap. Get it all set up and ready to go.
Yeah.
And if you have to do it, you just do it.
Right.
You don't have to go through all the steps to get it ready.
Yeah, I mean, follow your local protocols.
Absolutely.
If push dose epi is not in your protocols, maybe you should talk to your medical director about why.
Yeah.
Could you add it? Because I know that there's a lot of times where just a little bit of push dose epi keeps you from getting into that gray area of the hypotension, hypoxia, and that peri-intubation phase.
Yes. We use that a lot, just getting from the ROSC patient from the house to the ambulance, because where I came from, most of our rigs did not have the Lucas or the Autopulse, and so we would just give a little bump, even though their heart's still going, they still have pressure. We give a little bump just so we can get from there, point A to point B.
Yeah, we're kind of getting off the.
Are you doing that just real quick? Are you doing that
if they're in the borderline? We're not waiting for them to go down.
Right.
You mean like their blood pressure starts to drop or their heart rate or something? Yeah,
you can see the heart rate starts to drop.
Yeah.
Things are.
And are you thinking you're probably going to end up starting to drip on that patient anyways?
Yeah.
So you're trying to get them to the.
Yeah. And we're just trying to get them in the back, from the floor to the back of the ambulance, because we work our codes a lot longer on scene than some agencies do.
Mm-hmm.
And when you say push dose epi in that case, in a bump, how much are you giving an adult patient?
Depends on how focused I am.
Yeah, let's say.
Sometimes my bumps have been very, very big.
It's more of a boulder.
The first time I ever gave push dose epi, my partner handed it to me, and this is like, I think we only had 1 to 1,000 epi at the time, so you had to dilute it and then dilute it again. Anyway, we were flying somewhere, and he hands it to me, and I give it, and like I gave the whole thing.
Yep.
And so I gave him like.
You give him a milligram of 1 to 10,000?
No. So it was diluted. So I ended up giving him 10 mics, just like right off the bat. And I was like, well, it worked. It worked really good.
Yeah.
Anyway, that was an interesting call to our medical director.
Yeah.
Who he typically answered the phones. Holly, what did you do?
And what is the normal dose?
2 to 5. So.
Okay, that's
that's not a lot of epi. I'm just saying if you're going to use push dose epi, just make sure you know how to draw it up and you know how to give it.
Yeah. And that is smart because generally it's in one of those saline syringes where, you give a drug and then you whoosh.
Yep.
Yeah, I've done that before. So
So anyway, just going back to the checklist, put resuscitation on your checklist, whatever that means to your agency. Maybe it's a little bit more fluid, maybe it's some push dose epi, maybe it's blood. Maybe you can't do anything. Right. That's always the option too, is sometimes there's nothing else to do.
Well, and I think we get so caught up in, we're preached airway management. And while that is awesome, we have to recognize and respect the fact that none of those processes are super fast.
Right.
And you need to take the time to set yourself up for success, the name of this podcast, so that the patient has the best chance of success with the airway procedure you're about to do.
And think about it. If you have a patient with a soft blood pressure, maybe their SATs are borderline.
Yeah.
Do you need to paralyze and intubate them?
They're gonna
Can you just use a BVM?
Yeah, that's.
Can you just throw in an iGel without RSI?
Can you do ketamine? Can you do Versed?
Yep.
Can you do
like
what other
what
options
is
do you
airway
have?
management for this patient?
Right.
Yeah.
We have no way to resuscitate them. Let's say you can't do push dose epi. You don't have blood. You've given your 500 cc's of fluid or however much you give.
Yeah.
There's no helping the blood pressure unless you can stop the bleed, please.
Right.
But maybe you don't need to push the paralytic.
Right.
Maybe you can do something alternatively to do airway management, which is only ventilation and oxygenation. That's airway management.
Yep.
However you can achieve that.
And walking into an ER with a OPA, BVM, and suction unit is great airway management.
Especially if you can say,
this is why, right?
They've got a soft blood pressure. We can resuscitate them enough to do a paralytic.
Right.
Here you go.
Yep.
They don't care. Plus their resident gets to intubate.
Totally.
So the rest of the checklist, we've got, so then you have paralyze.
Paralyze.
Right? And then after the intubation, you're going to do your
Post-intubation
sedation and pain management.
Nice.
So,
which a lot of people forget about, but it's
we
super
are
important.
very bad about pain management with intubated patients.
Yeah.
We're so relieved we got the tube. They're on a vent. They have decent vitals, and we forget about the fact that, they're like a multi-systems trauma patient. And that's a big owie.
Yeah.
And we should take care of that too because they're still in pain even though they're unconscious.
And just thinking, if you put someone on a vent and they start fighting against the vent a little bit because they're not sedated enough, that can cause barotrauma.
Yeah.
So not only can you, you're not being nice, but it can also cause injury if you're not sedating well enough. Yeah. And that could just be some fentanyl and Versed.
Yeah, that's it.
Yep.
I remember going to 24-hour fitness once. This guy dropped a barbell on his toe. So his
Wow.
toe hurt.
Yeah.
What'd I do? I gave him fentanyl, right? But I'll stick a big tube down their throat and not give them any fentanyl.
Right.
Stick this blade in their mouth.
Yeah.
Yeah.
I mean, even in our protocols currently, it just says Versed.
Yeah.
It doesn't mention fentanyl.
Nope.
But pain control is very important along with the sedation.
Yep.
Which, if you don't have your checklist, you might forget.
Mm-hmm.
So
Awesome. Well, we've got a couple smaller things, I should say, on this to go over, but kind of give people some more tools or something to think about when setting up for success or using checklists in general. So another very brief case study that kind of goes behind this very simple tip, I guess I would give people, is we had a call in a rural part of our district for a gentleman with a stroke. Stroke-like symptoms, I should say, but he ended up having some pretty severe CHF, and we had to work on intubating him and getting a bunch of stuff done. So we're getting him in the back of the ambulance, we're transporting, and I'm with one other paramedic in the back, and this person is yard sailing the ambulance with everything they're opening, just creating a mess.
Were you working with me that day?
No,
Oh, okay.
no. And I hate messes. Like I get anxious. And I feel like a
wouldn't know that
weight
about you,
on
sir.
my shoulders when there's messes around. So I'm not in charge though. This guy is the lieutenant on the crew, and he's doing his thing. And he's at the Airway. The patient's been intubated successfully, and he drops the BVM. So at some point, he drops the BVM he opened and had sitting out, and we can't find it.
It goes in that black hole.
It's in a black hole.
Yeah.
There is so much garbage and wrappers and everything else around that we can't find this thing. It's literally gone. And so I'm watching this patient, because the monitor's going bing, bing, bing. And it's like, hey, boss, this patient's desatting. And he's like, yeah, I know. And I'm like, just grab another BVM. And he's so set on finding the one that he lost. The patient desats into the, very bad zones and goes into VTAC.
Oh, boy.
And I'm finally screaming, grab the PED BVM. It doesn't matter. We need to get this person some air. And so we end up grabbing a PED BVM and bagging them to the ER. And thankfully, getting the patient some air corrected their VTAC. But we were, seconds away from defibrillating them.
Oh, man.
And that was such a good example. And luckily, no untoward outcomes for the patient. But the rule that I tell all of my interns and guys on my crew is we have a clean zone when we in the back of the ambulance.
Mm-hmm.
It's not something. It's not okay to be messy back there because we don't have that luxury. And so when you open anything, take a rubber band off something, open up a plastic wrapper of any sort, all that trash goes behind you. And so each seat, the bench seat, the captain's chair, the CPR seat, they all have that little crevice back there between the seat cushion and the wall of the ambulance. Your trash goes behind you, and you stuff it down. Obviously, if it's a sharp, you're putting it in a sharp container. But that way, none of the trash ends up on the patient, and it certainly doesn't end up on the floor where the black hole of nothingness opens up and swallows up all the stuff that you're going to be hunting for if you drop it and you need it. And so there's the lesson. Clean zone, put all the trash behind you.
That's so true.
Jeez, I wish I listened to this 30 years ago.
I know.
I'm thinking back to like all the times of intubating in the back of an ambulance and that little tray area underneath like the radio and the airway stuff.
It just fills up.
It fills up with like gloves and drinks or whatever it is, like personal stuff, and then like garbage goes there. But that's where your suction is, and that's where your nasal cannula gets plugged. That's where the oxygen is. All the good things. But yeah, that makes a lot of sense. Mm-hmm. I used to always throw stuff in the wheel well. But it's harder to get there.
Oh, yeah. Just kind of lob it. Yeah. That would work too.
But while you're working, I like the idea of just throw it behind you.
Mm-hmm. The helicopter was horrible. Remember, just all be it. Your feet.
Imagine.
Oh, gosh, yeah. You mix that with the blood and, the
But
saline
going
bag,
from the ambulance to the emergency room, they are they're really messy.
Yeah.
I was like, why are we throwing stuff on? There's giant garbage cans here.
Right.
Why are you throwing stuff all over the floor? But,
Yeah.
of course, I got into it too, and it was
Yeah.
pretty fun, actually. But then if you drop something in there, you can just get a new one.
Mm-hmm.
But not in the ambulance. You're like
You're mad.
minimal equipment.
Totally. The next one was one that you guys brought up this morning, which I thought was awesome. The setting yourself up for success is knowing how your equipment works.
Yes.
And how to actually build it if need be. And the example was a nebulizer and CPAP.
Yeah.
And they're all different. Like if you're
Yeah,
working with another agency and maybe
Yeah.
you're in the back of their ambulance and they've got a different nebulizer,
Mm-hmm.
you need to know how it hooks up to your vent.
Yeah.
Or use your own.
That's how it is where we work. Is the ambulance has a different one than we have,
Mm-hmm.
and so I was going off the ambulances, and I learned 2 days ago how ours work, and I've only been there 7 months, so
Yeah.
bad me.
Yeah. No, but I mean.
But you don't use CPAP that much, and you certainly don't always nebulize when you use the
Correct.
CPAP.
Right?
But when you
Yep.
need it,
You need it,
You need
right?
it.
Yeah.
Right. especially on a vent where you can measure pressures,
Right.
Mhm.
if your pressures are super high, you're not going to ventilate that person because it's going to cut itself off
Right.
during that inhalation period.
And so I think one of the things that we talked about, and this was not my idea, but it was someone at my department's idea, and we've been doing it ever since. When you have something mission critical for those rare occasions that you actually need them, and you probably haven't looked at it, we created a little diagram and a label on top of a big Ziploc bag, and we pre-build those components. So the T-set that you need to build for your nebulizer into your CPAP is all set up and ready to go, and we have like 3 or 4 of them built in Ziploc bags with a diagram of, in case it falls apart or something,
Yeah.
of what to look for. But again, it's a version of a checklist. It's
It's perfect.
I'm at this step. Oh, okay. I got to make sure that these 4 things are put in the right spot so that I can do this, next intervention. But
Have you ever been sitting, I come from a long time ago, the private ambulance world where we would post.
yeah,
And I'll never
system
forget, I was
status.
sitting there with my partner one day. I was like, you know what? I haven't paced anybody in a while. How do you, I better go refresh my memory. So we get back there and go through it. No shit, the next call was you had to
Pacing
pace
call.
somebody. And I was
Right.
like, because it took us a couple minutes to fumble through it and be like,
Yeah.
oh yeah, that's how it works,
Yep. Mechanical.
That's
Yeah.
right. Yeah.
Yeah.
But it's not something you do very much.
No.
And I was just like, sometimes you get that for that. If you ever get that weird, I haven't done CPAP in a while.
I know, right? And then
Yeah.
You should
magically-
probably
Yep.
go and check it out. But there are certain things that we think we know how to do, and then we get to fumbling around putting it together.
Yeah,
Or even like pediatric dosages.
Totally. same thing.
Many times, like going down a pediatric seizure, I walked in on scene once, and the paramedic was pulling up the Versed and just sitting there staring at the syringe and then
Yeah.
the vial, and then just
Uh-oh.
turned around and handed it to me.
Mhm.
Like you
Make
just
this
kind of,
work.
yeah,
Yeah.
you just kind of, you think you know, and then
Yeah.
if you don't,
And I think
Yeah.
that's the lesson there is it's one thing to know, the dose is 0.1 milligrams per kilogram.
right? What does that look
And
like?
then it's like, oh, wait, how do I draw that up?
Yeah.
Have you ever dosed fentanyl?
Yeah.
Pediatric fentanyl from our 100 mics
Mm-hmm.
and 2 mils
It is not
concentration.
easy.
It's very difficult.
Yeah.
You need to water it down and everything else. And
Yeah. Once you get into like 0.25, you're kind of screwed.
yeah.
And think about, if we're sitting here talking about it and I got out the CPAP or the fentanyl right now,
Mm-hmm.
I'd fumble through it, but I'm not under any stress right now. Think about being under stress.
Yep.
It's going to really narrow my
It
vision.
will. Yep.
Mm-hmm.
So get that stuff out and look at it.
Other things setting yourself up for success, just personally, is I'm really bad at remembering to eat. In the mornings, I'm so busy doing things.
Yeah.
I get to where I'm going, or I get signed into work, and I'm like, I'm starving.
Yeah.
And then you're not going to eat for a couple more hours.
Yep.
So, even just taking care of yourself,
Self-care.
making sure
absolutely.
you do your inventory
Mhm.
on
Yep.
your rig, make
Having
sure
those
you have all the
emergency
things you need to
protein
do.
bars.
Yeah.
Those are huge. Yeah. Guys, that's it. We hit all the stuff we were going
That's
to
it?
talk about. Yeah.
Yeah.
So
I'm
much more
interested to see
say.
what other people do to set
Yeah.
themselves up for success.
Yeah. Feel free to email us. Give us a phone call. We'd love to chat with you guys about what's going on in your neck of the woods. And
You
what,
take phone calls?
Yeah. If people want them. Yeah, they can call us.
He doesn't
gonna
answer
call
my
you.
phone calls, but okay. I'm sure he'll answer yours.
Maybe you should change your number.
Probably.
Wait, isn't this Dan?
Dang it. He answers my phone calls.
Yeah.
Of course he does.
Yeah. Well, Holly's much more pleasant in general.
Oh, wow.
All right. Well, let's leave it there. And I believe we're going to have Ramsey back on the next episode next month.
Sounds perfect.
That'll be good.
Should be fun. We'll talk about more case studies.
Perfect.
All right, guys.
See you then.
Later.